Hello, hello, everybody. How's everybody doing? I don't talk at once. I got nothing back. Anybody? Can anybody hear me? Can I check my audio? Check, check. Mic check.
Check. I hear you.
Mic check.
I hear you loud and clear.
I hear you, Wade.
Oh, thank you, Claudia. Thank you so much. Good evening, everybody. Thank you so much for joining us. We still got a few minutes. We're going to let some others join us here. I see there's some connecting to audio, so we got more coming on here. Let me put my camera on so you guys can see. Yes, it's actually me. I know you thought there was someone else's voice, but it's me. Let's get our screen set up here.
Recording in progress.
Uh-oh. Let's behave. Chris, how you doing?
Doing pretty good. Pretty good.
Pretty good.
All right, just a couple more minutes, guys. Just a couple more minutes. 4:58. Now we gotta do a packed show here tonight for you guys. So just for those of you on right now, just to give you kind of some heads up, there's 3 different presenters tonight. This is a big topic we're tackling tonight. We're going to be talking about the management and treatment for severe asthmatics, starting anywhere from the ED all the way to the ICU, all the way to ECMO. Okay, so we have a full presentation tonight. So I'm going to try to get started on time because all 3 of us are so eager to present our information to you guys and, of course, entertain at the same time.
We're so eager to hear it.
I know you are, Kent. And we're glad you're here.
Are we going to start now? Are we going to start? Is it time to start?
30 seconds. Start the countdown.
29, 28, 27, 26.
Darren, where are you coming from? Where's your room at there?
Oh, this is my personal Congress library, that sits behind me. Just when I need to refer to Egan's or anything written by Dean Hess.
Excellent.
Maybe a little Jim Fink articles thrown in there.
I noticed you're kind of going for that Dean Hess look.
Trying.
For those of you who don't know who Dean Hess is, he's actually one of our pioneers in respiratory care. That's not only the director at Mass General in Boston, but he's also the chief editor of Respiratory Care Journal, who has recently stepped down and transitioned titles over to, gosh, give me a second. I'm forgetting his last name. Richard, yes, thank you. Richard Branson out of University of Cincinnati. I think he's getting to that point for retirement. All right, we're 5 o'clock. We're going to get started because, again, like I mentioned, for those of you who just joined us late, my name is Wade Veneman. I'm one of the clinical educators for respiratory care. Tonight, we have a special presentation for you guys. We're going to be talking about management and treatment of asthma from the ED all the way to ECMO. And I have some special guest presenters with me tonight. I've got Chris Prince, our pediatric coordinator at CRMC. Give him a wave, Chris. There he is. And then the one and only Darren Kraft will also be presenting.
Hello, everybody. How are we all tonight?
So when we get started here, the first thing I'm going to talk about is a really important concept that we kind of live in, day in, day out with our lives. And, it's a general term of respiration, but it's a really important concept because most of the time with all of us right now breathing normal, our healthy lungs normal, there's kind of this quick old saying, you know, air goes in and out, blood goes round and round. And really what we're talking about is air going in is oxygenation. Air going out is CO2, carbon dioxide, right? That's our dry debris. So we're just trying to exhale it. And then blood goes around and round with circulation. Okay. But remember, any deviation of this problem, this concept right here creates a problem. And tonight, that's what we have a special presentation for you tonight about a severe asthmatic presented in our ED that we want to discuss and what treatment tools we have in our hospital to talk about. So for our learning objectives tonight, it's kind of, like I said, broken down into three sections. The first section you're going to hear about is our patient arriving to the ED, and we're going to discuss all of our treatment and management options for severe asthma in the ED. And then we're going to transition into discussing and understanding implicit bias. There, believe it or not, you know, there's not one way to ventilate any type of patient, any type of modes, and even physicians sometimes don't agree with the same processes. So we're going to discuss a little bit about that. What is the best way to manage these patients on a ventilator with severe asthma in the ICU? And then last but not least, who's going to close this presentation out for us tonight is Darren, and he's going to talk about our options if our patient's failing conventional ventilation, secondary to hypercapnic respiratory failure, hypoxemic respiratory failure, whichever one it is. What else do we do? What else do we have in this facility as tools or options that we can take care of these kind of patients? All right, so Chris is going to open it up with our patient.
Thank you, Wade. So let's get into our patient here. She's a 21-year-old female. She has a long history of asthma. She's been sick for the past 7 days and progressively gotten worse over the past 3 days. She's been on maximum therapy for inhalers, her steroids, her long-acting beta agonists, her long-acting muscarinic antagonists. So she's got a real long, severe history of asthma here, and she's just been progressively getting worse. So our patient, she comes into ER. She's extremely anxious, very decreased breath sounds. Her heart rate's already in the 150s from all the albuterol that she's received on her transport in. She's satting in the low 90s. She's received multiple bronchodilator treatments. Like most of our patients that come in, you see them coming in with this, real tachycardic, anxious, they can't breathe, just real air hungry. Right? We've all seen those patients come into ER. So we decided to set her up on some BiPAP ST with a 18/10, the rate of 10, and 100% FiO2. So we're hoping to kind of catch her early and prevent some intubation. So let's see what her blood gas is. So here's her blood gas. Do you guys see anything here that really stands out to you? And if so, what do you guys think is the biggest problem here?
CO2, she's air trapping big time.
Yeah, CO2's way up there. pH is way down. All right, let's go next here. So let's review asthma really quick here. And the reason I want to review asthma, it's very important when our patients come in, pediatric and adults, that we talk to them about this, because remember, we're all educators here. It's important that they come in, we talk to them on how to control their asthma, because our goal is to really improve their activities of daily living, reduce their days missed at work, and then reduce hospital admissions. That's our overall goal. So what are the characteristics of asthma here? Let's look at, we got airway inflammation, right? That's a huge thing. A lot of mucosal edema, which irritates the airways and then causes more mucus plugging. Mucus plugging is a huge thing. And then the airway hyperreactivity, right? That causes bronchospasm. So when we talk to patients, we got to talk to them about this and controlling each one of these, because it's very important. Controlling this and not having admits is extremely important. The screen doesn't want to move. There we go. So this is a clinical manifestation of status asthmaticus, right? There's always a trigger. Something happened. There's lack of control, right? So they have increased risk for bronchospasm already. They're inflamed. They're outside. They're not taking their medications. Maybe something happened. We've had a patient that their dog ate their spacer. So talk to the patients when they're here, if they could talk, right? When we're educating them later on, see what we could do to help them out. Because sometimes it's just a simple thing as like actually getting them a spacer or just talking to them about taking their medications properly. That'll help prevent them from being readmitted. So let's get into our initial therapies here. Hold on. Oh, so we're going to discuss our treatment options before intubations, like our continuous medication delivery, which downtown here we have options of providing a continuous aerosol with aerogen and a syringe with a medfusion pumps, non-invasive options, and we'll talk about Heliox therapy as well. So our initial therapies, everybody in ER gets albuterol, you know, when they come in for asthma attacks. Even if they don't come in for asthma attacks, they still get albuterol because we like to give that drug out. It's our favorite drug. So, you know, systemic oral inhaled steroids is always good. Look at this patient here, you know, receiving albuterol. Our pediatric patients, that's what almost all of them look like. They're so happy to receive this. You guys, is this mostly what you guys see in ER? Our patients come in, they're this happy getting treatments? It's no, never cried. So that's been my experience right here with these peds patients. We also want to start them on some non-invasive respiratory support, high flow nasal cannula, or BiPAP. And or on Heliox too, we have that option available to us as well. In the bottom right-hand corner here, this is our medfusion pump with the aerogen syringe on it. That aerogen syringe is proprietary to the aerogen controller. So it's a great way to deliver continuous nebulization for our patients on non-invasive support. So our non-invasive options are with our high flows. Here we have OptiFlow Adult and OptiFlow Juniors. Over here in the right picture here, that's an adult OptiFlow with an aerogen inline. BiPAP, we have two types of BiPAPs here, the Trilogy 202. That's used for all of our pediatric patients under 20 kilograms. And remember, the V60 is only used on patients over 20 kilograms. All of these devices can be used with Heliox as well. And remember, with our goals for SATs, they don't have to be 99, 100%. We could keep their SATs on the lower side and they'll still be okay. So using non-invasive ventilation, it's really important to pick our patients because if we don't pick the right patients, they can fail and deteriorate rapidly, and they can have an increased chance of a poorer outcome. I mean, an asthmatic that's getting intubated is already at a high risk for a poor outcome, but we don't really want to delay that, you know, so we do not want to delay intubation if we don't have to. So make sure that our patients, you know, are awake. Their respiratory rates are less than 25. Their SATs are 94 to 96 on oxygen already. So they're not sat like 90 on oxygen. So that patient's really at a high risk. They can have a little bit of hypercapnia, which most of our asthmatics will. And of course, they're going to be severely short of breath. Now, once you initiate a therapy like this, you really want to watch their heart rate and their respiratory rate. You want to see improvement in less than an hour. If they don't improve within that hour, you're probably going to have to escalate care. So anytime you put these patients on any device, always have a plan B and be ready for that plan, ready to implement that plan. Definitely altered mental status, a decreasing level of consciousness is a huge indication this patient's going to fail. So just don't delay intubations. Have everything ready to go just in case this patient fails. So Heliox, we'll cover Heliox really quick. It's a great tool to really help decrease auto PEEP, to improve medication delivery, and to really improve the overall patient's respiratory status if they have asthma. So these illustrations here, the one right in the middle of the screen shows a normal airway receiving oxygen, right? So the laminar flow down the middle of the airways, there's a little bit of turbulent flow on the outer airways, but this is all a normal airway, the way the gas flows through there. Now, if you look at the one next to that, so the upper right-hand corner, that's a patient that has bronchospasm, inflamed mucosa, and mucus production in those airways. So that patient is not on Heliox. That airflow is extremely turbulent. So our asthmatic patients, they don't have as much trouble getting air in, but they have a lot of trouble getting air out. So this is a huge issue for them. Those three components really make it difficult for them to get that gas out. So in the bottom middle of the screen, that's a great illustration of a patient that's receiving Heliox. That Heliox gas is less dense. It creates more laminar flow down the middle of the airways. So it will help decrease auto PEEP. It'll help improve, improve medication delivery to those lungs that are further down that are more constricted. But it also It doesn't cure anything. Just think about that. It's just there as a tool to help the patient get over this initial respiratory distress, this acute phase, and to help them get better. It doesn't cure anything. It just provides time. Heliox is best used when the concentration's over 70%, but don't you can still use less, but it's better at a higher concentration because it does help the patient at higher doses. So we do have these tanks available to us. There's 2 boxes. We have 2 of these blenders. So it's a great tool. It's easy to get to, and it can actually help your patient prevent them from being intubated. So thank you. I'll give it over to Wade now.
So unfortunately, thank you, Chris. So unfortunately, our patient didn't make it that far, and we had to intubate the patient. You know, obviously, you guys saw the first gas, and it was very concerning. I would say almost borderline cardiac arrest, hemodynamic compromise. Now, the thing that stands out to me here is by the time they finally decided to intubate this patient, you see I highlighted in red there, they were only able to get a 6.5 endotracheal tube in this patient. And I think one of the lessons we always learned with asthmatics is put the largest tube you can in this patient, because we're dealing already with a significant amount of airway resistance. And now adding the resistance of a smaller diameter tube is going to create even a bigger challenge for us. So for the vent settings that was chosen for this patient, they started with pressure control of 28, okay? Tidal volumes with that pressure was roughly around 140. So, you know, like earlier Kent said, you know, with auto PEEP and trapping, we're not getting much air out of that patient. The rate was set at 25. And again, I'm going through these slow because I want you guys to start thinking, would I put them on that setting? Because when we talk about the recommended settings, rate of 25 is a little on the high side. I time of 0.75. And the reason why it's probably shortened because they were trying to get the maximal IDE ratio for more exhalation time, but you're still not going to get that long of E time with the rate of 25. The rise time was set at 0. I'm just going to tell you right now, with everything that I've learned, with a smaller the ET tube is, the higher the rise time needs to be. I mean, Chris just did a great job explaining how Heliox works and about flow. And when you have a mad rush of flow coming from the ventilator circuit, large bore tubing down to a small endotracheal tube, is going to meet resistance. Okay, a lot of that pressure is shut off or terminated, and the patient really won't get much delivered to them. So we need to think about those settings. And you know, these are the things that makes us experts on the vents for us RTs, because this kind of setting is not in an order, right? The doctors don't tell us set the rise time at 1 or 0, whatever. These are things that we should be analyzing on the vent screen, on the patient worker breathing, and setting it up. And then the starting PEEP they went with is with 12. Now, our goals mechanical ventilation with asthmatics is obviously number 1 is decrease worker breathing. I think we all agree with that. Augment alveolar ventilation without causing iatrogenic harm. Hopefully everybody on the call understands iatrogenic means. That means that's harm caused by us, okay? And there's many times that I've mentioned that anytime we put a patient on a ventilator, we can cause more harm. And that's why we you know, spit out terms like lung protective ventilation, using low tidal volumes and things like that, because we're trying to prevent harm. We're trying to prevent ventilator-induced lung injury. There is such a thing, and there's 4 traumas. And I know most of you guys have heard me talk about them. But also remember, just maintain adequate. Like Chris said, we don't need these patients with PF ratios of 300 plus or sat in 100%. Just maintain adequate oxygenation, because usually that's not the problem with these patients. Now, I'm not here to tell you there's one special mode to put an asthmatic on. There's several opinions, there's several theories out there. If you ask me personally what mode, I'll tell you which one I would put them on. But for this presentation, really, whether you pick a volume mode or
SIMV.
oh no. Hopefully all you've noticed that I didn't put SIMV on the screen. That's a whole different lecture. Chris maybe will chime in on SIMV for us. But if you pick something, whether it's volume or pressure, again, try to keep their tidal volume somewhat normal. So 6 to 8 mLs per kilo predicted body weight is a normal tidal volume. That's all you need to ventilate these. You don't need to crank it up too high. I know a lot of people, when they first looked at that blood gas, they saw the CO2 of 170. Okay, and then they saw the pH that was highlighted red. But again, look at both the combination. But the CO2 is 70. A lot of people want to just put them on the vent, crank up the settings really high, and try to ventilate them within an hour. And that's exactly where you're going to get. Darren, will you get this gnat at? Sorry, guys, I got a bug flying around. But think about that. We don't need to make that time. We need to really fix the pH and get that up in a more safer zone. Get that up somewhere around 7.15 or 7.2. You know, the CO2 we know we can tolerate permissive hypercapnia, but we really got to focus on getting that pH. But we can't do it in 30 minutes or to an hour. So think about the ultimate settings. Again, the respiratory rate should be somewhere the lowest possible to set, so you get the maximum IDE ratio, specifically the E time, is what we're focused on. We need to give these patients time to empty. Remember, they're completely hyperinflated. They've got a lot of auto PEEP, intrinsic PEEP, whatever term you want to use, but we need to get that gas out of their lungs. FiO2 is again somewhere, 95. It could be a little bit less. Now, end-tidal CO2 is always a good tool to trend, and a lot of you understand end-tidal. It tells us two things: ventilation, perfusion. But one of these terms that I got on the screen there, does anyone tell me what that means? What does VDVT stand for? Anybody?
Dead space to tidal volume.
Excellent, Brian. Thank you so much. So remember, we have a dead space. So when we talked about this previous slide, it said alveolar ventilation. Okay. Remember, alveolar ventilation is subtracting out the dead space. And what are we dealing with here? We're dealing with a lot of gas that's not participating in the gas exchange. Because I think Ken identified that right away when he saw the blood gas and knew they're air trapping because the gas isn't coming out and the CO2 is so high. So end-tidal is another good tool here. And again, we're trying to not create a normal end-tidal, but we're trying to trend it and monitor it based off the gas and the end-tidal and look at the gradient between the two. If the gradient's within 10 or somewhere like that, we're doing well. If you're making changes on the vent and the gradient starts widening and getting farther, we're going the wrong way and we're increasing more air trap. And then PEEP, the recommended PEEP standpoint is, again, going to be a controversial topic that I've got a couple of slides on, just to make sure that everybody understands the bias between using PEEP and the right way to use PEEP on asthmatics. So again, one of the most popular modes from a volume standpoint is dual control, or a lot of us know them on our ventilators as either PRVC, VC+, or PCVVG, autoflow. All these other ventilators have some type of dual control, but the advantage of a volume mode is you get to set a rate and a tidal volume, which guarantees minute ventilation. The advantage of dual control versus volume control, let's say, though, is you actually have an algorithm built in the device where it's actually titrating the lowest possible pressure to achieve the tidal volume based off compliance and airway resistance. So if you think of an asthmatic or COPD who has increased airway resistance, you're like, well, okay, this might be a good mode to put them on. But I do caution you, if you do attempt to use this mode, maybe a lot of you have experienced this before, is remember the algorithm. Okay, because if you set a tidal volume of 500, and let's say I've got someone like Darren on the ventilator, and he wakes up and he's just taking these enormous breaths. His inspiratory demand is just taking these big, giant tidal volumes. And now I'm looking at the vent, and it's exhaling 750, 800, 850. What does the algorithm say to do? Well, if the tidal volume is more than what the set volume is, it's going to start titrating pressure down away from that to get back to the tidal volume. Well, what does that do to Darren? More distress. Darren is going to create more worker breathing because think about it, it's taking support away from the patient. The patient's trying to breathe on a vent, we're trying to support them. But if we got them in a mode that actually doesn't support them, then you're just going to cause more problems, more issues down the road. And then some people will come in and say, well, they might be agitated, their worker breathing's up, maybe need to paralyze them. There's other options out there, but sometimes we can let our patients breathe, optimize the setting. So sometimes I want you to be careful of this. And the clue to this is your airway total pressure, instead of being, say, around 40, it's going to be down around 10. It's usually 5 above your PEEP level. So if your PEEP's at 10, the total airway pressure will be 5. When you start seeing your numbers reduce like that, then and you look at the patient, they don't look normal, their worker breathing's up, then that's when you need to switch over to the mode.
So you mean to say that my compliance shouldn't be 150?
No,
Oh, okay.
I'm actually not even sure if that's possible on a ventilator to have a static compliance of 150. I could be wrong, though. I don't know what the new Egan's book says out there, though. They could have changed the ranges.
It's for DKA patients only.
Okay. DKA, that's another good topic. Okay, so what about pressure control? So again, let's think about pressure control for a minute. We get that rapid flow delivery. So if you've ever want to know and understand, for those of you that may not, I know we have not just RTs online, And if we think about mechanical ventilation, and the three main modes are really volume control, pressure control, or the dual control mode. If you look at the way the flow is delivered, you either have one that has a fixed flow that's set, and that's all they get. You have a variable flow, which is dual control, what I just explained to you. And then you've got something like pressure control, who's really is unlimited flow. It's basically on demand. If you want to take a big deep breath, the machine's going to give you the flow. If you want to settle down and relax and calm down, then the flow is going to decrease based off your demand. But it has that demand. So back to the scenario with Darren, if he starts waking up, taking these big giant breaths, the machine will start escalating the pressure and support him with the flow, and then his work of breathing will come down. So it's the complete opposite of the dual control. So you get that rapid flow on demand. Also, you're able to maintain your airway pressures. Again, when we talk about what are the main things to monitor on these patients, peak airway pressure is somewhat important, but when we're talking about airway resistance, we need to really focus on alveolar pressure or plateau pressure or static pressure, whatever term we're using this week. But those are the really keys that we need to do that. However, a disadvantage of pressure control is it does not guarantee a minute ventilation. So again, based off someone who we're trying to ventilate, we need to make sure that we're in the right thing. So for example, if my tidal volumes are 500, I come back in 2 hours and now they're 300 and now they're 200, my minute ventilation is decreasing. And now I know my CO2, I'm not ventilating the patient. If they're paralyzed, they're not going to be able to pick up their breath. So we need to monitor these patients very closely because they can change very quickly. So if you look at a standard pressure cartoon here, we'll call it, with the PIPs, again, we always been trained to keep PIPs less than 40, but with asthmatics and severe airway resistance, we have to consider that if a PIP of 45 or peak airway pressure of 45, it's okay, because what is my plateau pressure? That's the question you need to ask. And I think if you guys are looking on the screen or following along here, the PIP reading is the very total pressure at the end here. But when I do that inspiratory hold to get my plateau, for this example here with a patient who has increased airway resistance, look how much the pressure drops down. And your plateau, if this is 40, this might be 25 down here. So that's why it's really more important to follow the alveolar pressure or plateau pressure on those asthmatics to keep an eye on this. Now, the opposite would be our poor compliant patient or ARDS patient, where you take this patient as a PIP of 40 and you do an inspiratory hold, and what would you guess their plateau pressure is there?
40, 38.
Right. So typically there's not as much airway resistance in that type of patient, but compliance is poor. So that's what we need to keep an eye on. And this is what we're looking for in these kind of patients. Now, there's really two theories out there to utilize or optimize PEEP on these asthmatics. And again, you can probably go back and forth with, depending on which paper you read, depending on which physician you speak to. This might even be which RT you speak to, okay? But just for me tonight, what I'm explaining to you is the two different options or theories out there that they go by. And again, I have 2 pages of references at the end here if anybody wants to read into these papers. So one of them is, and I've even caught myself, and I'm guilty of this in the past, is said set your PEEP to match the auto PEEP. But notice I scratched that out because I'm like, wait a minute. If you do an expiratory hold and you got a total PEEP of 20, necessarily I don't need to set that PEEP at 20 to match it. I shouldn't be doing that. I've always said in the rule about 2 to 4 below the total PEEP, okay? But then I started reading and I go, well, what's actually recommended out there? And this is a 2013 paper by this guy named Omar here. And he's looked at this, and the way he described it is you want to have some PEEP on board to dilate the airways in order to reduce the airway resistance, right? Because then we get air out of the lungs. If we get air out of the lungs, then we decrease work of breathing. So what they recommended is somewhere between 75 to 85% of your total PEEP. So for example, here, I did an expiratory hold. I got a PEEP of 20. I times it by 0.8 or 80%, just took the middle between the two, and I got 16. So 16 might be the upper end of that. Now, there is another way to look at it, is I've always looked at the total peak pressure. And let's say my peak pressure is 40, and I start a PEEP of 5, I'll raise it to 10, and I look at my airway pressure. And again, I'm in pressure control, so I'm controlling the pressures. If my peak airway pressure stays at 40 and I've moved this up to 10, then I know I haven't created any more intrinsic PEEP yet. So then I go to 12. Let's say everybody loves 12, right? Optimal PEEP. Again, if my peak pressure stays at 40 and I'm at 12, I'm making grounds and I'm actually moving dead space out of the way so I can expiratory flow. Now I might go to 15 and now I see my peak airway pressure jump to 42. Then I know I've gone too far, back it back down to your previous thing. Again, we have all these tools in front of us And this is the things what we're trying to demonstrate tonight, what you need to look for when you're billing these patients. Now, it's also been described in this paper, and I thought it was interesting that looking at an analogy of a waterfall. So if you take this cartoon here that's looking, this is your overdistended intrinsic PEEP-filled alveolus, okay? And if you look at from the alveolar duct and the airway here, right here is the problem, right? This is where the bronchospasm is taking place. And so what we've always labeled this, and some of you may have heard me talk about opening and closing pressure or critical closing pressure. This is kind of what they're describing here, is this is where the critical closing pressure is. So what we need to do to get the waterfall running here is we need to use PEEP to stent this area open right here. I don't want to match what's total in the alveolus here, but I need just enough PEEP to stent this airway open so I can get this gas out of the airways here. I want to see everyone's heads nodding right now, because if it was on a live class, I'd have everybody paying attention because this is important. But you know, with Zoom, we have restrictions on this. It's kind of hard and to see your guys' response. But hopefully that makes sense what we're trying to demonstrate here, because it's a very important concept with the PEEPs. Now, the other theory behind this is you might hear somebody say, no, don't put any PEEP on them because they already have enough PEEP on board. They have all this intrinsic PEEP. So if I add more PEEP, I'm going to give them or add to the total PEEP. Now, again, I'm going to argue on the other side that I like the other way to set PEEP. Again, that doesn't mean I'm right or wrong. But you might run into like I said, this is our implicit bias standing here, where we need to understand there are different theories behind this. There have been many conferences, papers, you name it, pro-con debates back and forth about utilizing this back and forth. But again, they say not to use PEEP because it increases end expiratory lung volume, or remember another term for that is FRC. I don't know if there's actually any actual measurements of data on that, or it's just based off of theory, but yeah, think about it. How does that increase? Because I've always said in the past, not the biggest FRC is the best FRC, right? You still want to optimize FRC for the best gas exchange. So there could be some truth to that. Also, like I said, they think it'll cause more auto PEEP or more hyperinflation, causing hemodynamic compromise and more barotrauma. Okay, well, we want to maintain lung protection here at the same time. So these are valid points that we need to still consider. Like that other patient, maybe if it was 20, maybe I'd be a little risky going to 16. Maybe I'd just stick to 12 or something, like 10 or 12 from a safe point. Look at your exhaled tidal volumes. If you look at this graph here, the same thing kind of demonstrating down here that with zero PEEP, you have really no airflow movement at all with the total. But as you start slowly incrementing your PEEP up to 5, up to 10, notice that this kind of reminds me of, I think, did I saw Kurt? Is Kurt on here? Kurt, this kind of reminds me of when we look at the bottom of the VDR waveform, when we talk about tidal volume, right? Because I'm like, as we move more PEEP up and up here, and we start matching that total PEEP intrinsically, I look at this as exhaled volume. I'm like, wow, I can move more gas now if I start doing that. So if you're still not sure about what PEEP to set, just try to stair step it a few steps at a time. Go to 5, go to 8, go to 10, look at your exhaled volumes, look at your total pressures, and kind of get an idea of what works best for that patient. Because remember, I'm not saying that this includes every time an asthmatic gets intubated, you should do this theory. You need to individualize care for each patient. Okay, so back to our patient. Here's our first blood gas after our setting. So now if you look back at our settings, pressure control 28 and a PEEP of 12. So we've got a total pressure of 40 with a PIP of 45, okay? Tidal volumes are not much at all. Rates 25 in the eye time. So now you can probably identify a few clues here that our PEEP might be too much because you see the pressure is at 45 and I got a total of 40 here. So PEEP might be too high, but also look at our exhaled tidal volumes. Maybe we could argue the PEEP's not enough, right? We need to add more on there. Decrease this though. You know, we don't need that much driving pressure to push in. Remember, asthmatics don't have a problem getting gas inside their lungs, right? They have problems getting gas outside of their lungs. So you don't really need this much pressure moving in their lungs. So I would probably almost start flip-flopping these, decreasing this by 2 and adding 2 here, trying to target that. So kind of just food for thought there to think about. But anyways, our blood gas is 6.83. CO2 actually went up to 180. Our pH went down. Hey, we're ventilating or we're oxygenating, you know, but again, that's not going to last long. We'll tell you that right now. That's not going to last long. They're 100% on the vent, but that's not going to last long. Because you can see here, your base deficit's already -7. So this isn't purely respiratory acidosis. You've got a combined acidosis. I'm sure, Chris, what do you think the lactate is on this patient?
Oh, I'm guessing probably 12. 13. It's probably pretty high.
Yeah, and, you know, and I apologize for the group that we don't have it on here, but that's probably an important indicator that yeah, we're getting pretty close here. So again, I think we're putting the patient now at more risk for hemodynamic compromise, cardiac arrest. And again, remember I talked about Billy, try to protect the lung without happening. Well, unfortunately, that didn't happen on these settings. So can everybody see the screen with the chest film? Okay. Anybody still out there?
Yeah,
One, two.
hyperventilation.
Okay, good.
I see something on the right side that appears to be a lack of lung markings
Yeah, that's a pretty significant pneumo.
and the straightest endotracheal tube I've ever seen in my life.
Stop making fun of my tube. So perfect, Jonathan. Thanks, John, for pointing that out. So what Darren was talking about, if you can all see the screen here, if you follow this path here, here's actually the shape of the lung. It actually goes about here. This is actually the right lung here. Now, again, all those pressures, all that hyperinflation, what's going to continue to happen is everything's being pressed this way. Okay, you can already see somewhat of a shift, right, of the trachea moving. Now, what's going to happen here is this heart's going to get squished. Then what happens, Darren?
Well, that's when we start having hemodynamic compromise. Your patient starts getting tachycardic, they start getting hypotensive, and then the next thing you know, you hear beep.
And you might even see bradycardia first and then drop down, right? All right, Darren, what else we got? So we got a pneumo, we got to put a chest tube in this patient. You know, conventional ventilation is not working. What else can we do?
Oh, I'm glad that you asked. Hey, good evening, everybody. Thanks, Wade. That was a great job. So here's what happens with this patient. No matter all the magic that we can do, everything that we've done, everything that we've tried, it seems that we weren't able to fix it with the vent. So
We're getting feedback.
hold on here. We're trying to figure out some feedback.
Yeah, I'm on mute.
All right, let's see if that's any better. Everybody hear me?
Yep.
Can you hear me now? Okay. All right. My computer decided to foul up the microphone and turn on two mics. So anyways, we've done everything we can. We've tried every trick in the bag, and we're just not able to ventilate the patient. As we can see now, we're going backwards. We're down to a 691 with a CO2 of 176. This is a good time to remind everybody that we can't always fix them with the vent. We have a patient up on T5. We cannot always fix them with the vent. And so we have to remember that there are other things that we can do. At this point in time, the ECLS team, sorry, we're trying to do some remote controlling here. So the ECLS team comes in and they take a look at the patient. For anybody who doesn't know what ECLS is extracorporeal life support. So the patient gets consulted by the team and they say, yep, we're going to go ahead and say that this patient meets criteria. Well, everybody hears that. Does everybody know what the criteria is? Well, here it is up on the screen. So at a mortality rate estimate of greater than 50%, they're considered to be acceptable for ECMO. However, if they go above 80%, then that's the criteria. The PF ratio is less than 150. Now, if we're looking at this patient here, the PF ratio is kind of on the fringe. It's at 192. But some other things that we need to pay attention to is that we are not able to ventilate the patient. We've got a high CO2 despite high plateau pressures. We have now developed an air leak syndrome, which as we saw in the previous x-ray, she's got a pretty big right-sided pneumothorax. And then the other thing, a lot of people kind of come in and they ask like, okay, why does ECLS team not consult on this patient? Why did they not accept this patient? Well, some of the things that they have to kind of dance around a little bit is the medically standard optimal care. This is saying that everything was done as medical standard. And a lot of times people will understand this as like low tidal volume strategy. It's very hard for them to check the boxes when the patient's on VDR or when the patient's on bilevel. So sometimes that gives a little bit of a hiccup. Sometimes the patient can meet criteria in so many other avenues that they can go ahead and bypass this. But let's go ahead and look at the patient a little bit closer and let's look at ECLS. Come on, computer. So this patient gets selected and they decide that they're going to do VV ECMO and they're going to use the Avalon catheter. Well, the Avalon catheter has kind of gone away, and we're starting to use a new one called the Crescent, and I'll identify some things about that. So what is ECLS? I had identified that before. It's extracorporeal life support. The two most common types, now there's a dozen types out there, but the two most common types are VV ECMO and VA ECMO. Now, the original design for VA ECMO was actually ECO2 removal. So this is basically, it is a small catheter that goes just through an oxygenator and does not have a pump involved. It goes from high pressure side to low pressure side. And it is, all it's doing is just removing CO2, and that's the ECO2R. This patient we're going to talk about today, VV ECMO, the blood is returned to the venous system. So one thing that we have to remember is that the patient, the blood is still going through the innate system in the patient. Now, how does this affect us? Well, if you've got a lung that's completely collapsed and the SVR or the PVR, the pulmonary vascular resistance is really high, you're not going to be able to pump blood through, and you're going to see things like dilated right ventricles. You're going to see high pressures in the circuit. You're going to see the patient not turning around quite as quickly as you thought they would. The reason why is the blood is still fighting against all that pulmonary vascular resistance. One question I love to ask everybody, it's the same thing with the ventilator. It's the same thing with Heliox. Does this cure or treat anything? Wade says no. Does anybody think that it does? I'm going to go ahead and agree with Wade that this does not cure and treat. The only thing this does is it allows us to rest the body. It allows the patient to heal themselves, or allows medications to come into play. It is extremely effective at CO2 clearance. That's why a lot of times, as soon as you cannulate a patient, the first thing you notice is the CO2 plummets. And in this case, this is another scenario where that happens. Another beautiful thing about VV ECMO is the single site capabilities. Now, with the single site capabilities, there is so much of a lower risk of infection. It's easier to put in. They can do these at bedside. The patients don't have the risk of bleeding as much. They don't have to heparinize them as much. They don't have to go to OR. There's a lot of advantages to the single site insertion. The other thing that they don't have to worry about is recirculation of the blood, which is where it's going in one cannula and coming right out the other cannula, and it never really sees the body. Now, this little cartoon here is showing kind of the conventional ECMO circuit and how it works. So you've got your air and oxygen flow meter. It's an exchanger, right? And this is pumping blood. So this is your sweep gas, okay? So this flow meter is your sweep gas. This is your FiO2 on your blender. This is going in, and it's actually blowing across the capillary membrane of the oxygenator. Now, the oxygenator on the other side of it is got blood coming in and going out that's coming in via the pump. Now, on the ECO2 removal, this pump is not here. It's actually just going through on blood pressure. Now, on a single site insertion, you can see that it's coming in to the IJ, to the right IJ, or the right internal jugular. It slides down through the superior vena cava, goes through the right atrium, and rests distally in the superior vena cava, or I'm sorry, the inferior vena cava. I got all these words jumbling around in my head. Well, the important thing to remember here is it has two ports that actually pull to the pump. One is above the atrium in the superior, and the other one is below the atrium in the inferior. And where it returns it in one place. Now, the one place that it returns it to is in the right atrium, and it is actually forcing that stream of blood right into the tricuspid valve. So as soon as the tricuspid valve opens up, it forces blood into the right ventricle. Now, this is where, when I was talking about high pulmonary vascular resistance, where this comes a problem, is you start seeing this globally dilated, this huge round right ventricle. And a lot of times that is because of the pressure that the ECMO circuit is increasing into the right ventricle, but it can't go anywhere. So the patient technically has really high pulmonary hypertension. Now, here is a video. Unfortunately, we don't have a lot of time, but this is a video here. If anybody's interested in watching it, I can send you the link to it, or you can come in by the office and we will watch it. Now, back to the patient. So when you're first setting up your ECMO, there's a lot of questions like, okay, what's our basic settings here? What are we doing? Well, the sweep gas, they're titrating the sweep gas to maintain a pH of 735 to 740. The FiO2, a lot of times they like to keep it at 100% for the first 24 hours. Blood flow, they want to keep it within acceptable pressures. They want to make sure that those proximal pressures aren't going up really high, because remember, the pressures in the ECMO circuit are also reflective of the pressures in the patient's arteries. They're going to look, make sure that the catheter is in place. Well, they used to do echoes, but with the new crescent catheter, it actually has radiographic markings, so they can see it in an X-ray. And then they want to make sure that they don't have any recirculation, which with a single site insertion is not really a significant issue anymore. Vent support, we're going to follow along with what Wade had talked about earlier, and we're going to keep that plateau pressure less than 30. And we're going to try and target those tidal volumes between 4 and 6 for lung protective strategy. But every once in a while, you're going to see an order for ultra lung protective. And that's going to be targeting tidal volumes between 2 to 4, most likely at 4 mLs. What do you think about that, Wade? You think you're moving CO2 with that one?
Wait a minute, did you just say ultra lung protection?
Boy, yes, I did. Ultra, super duper lung protective strategy. And believe it or not, guys, that is actually a legitimate lung protective strategy. It's mechanical ventilation. So you're going to use really low rates. You're going to use rates as under 10, and you're going to use little teeny tiny tidal volumes. And these are mostly just to kind of keep the lungs open and working. Your FiO2, you're going to drop it down to about 30%. You're going to keep your PEEP down, less than 12. Because right now, what we're focusing on is resting that lung and letting it repair itself, letting everything go get better while the ECMO is supporting the body. Okay, come on, screen. All right. So, hey, so we do a blood gas on the patient. This is the first blood gas, and we've got a 725, a 44, PO2 at 98. Huh. We got PO2 at 98. Ignore this down here, this ECMO of 0.3%. That's a total mistype on my part. What I'd like to point out, though, is we've got 100% FiO2 over here and a PO2 of 98. So a lot of people would look at this and go, well, wait a second. Why is this patient's PO2 only 98 if they're on 100% ECMO? They should have a PO2 in the 500s. Well, I'm glad you asked that, Wade. The reason why this is happening is if you look at cardiac output, normal cardiac output, what, 4 to 6 liters a minute? We've got an ECMO here that's pumping at 2.8 liters. So some of that blood flow, some of that normal blood flow is bypassing the ECMO circuit completely and it's going through the blood system. So what you have here is about a 3 liter a minute shunt of just unoxygenated blood, poorly oxygenated, poorly ventilated blood that's coming through. So your CO2 is going to be up and your PO2 is going to be a little bit down. We still have that metabolic acidosis that's going on, so we got to keep an eye on that. But as you can see, our vent settings, we still haven't really changed our vent settings to a more optimal tidal volume for this patient, but our rate's down a little bit and our PEEP is coming down. So what was wonderful about this is if you look here, this patient at 1:12 in the morning gets put on, gets her first blood gas on ECMO, and at 7:04 in the morning, they're doing SBTs. Now she's still on ECMO, but we're going to do an SBT, and this is our post-SBT gas. So, hey, patient's doing great. What do? We go ahead and extubate them. What? Extubate on ECMO. That's one of the great things about ECMO is if the patient can be made comfortable and they can be gotten up and moved around, we can resolve a lot of those pressure demands, a lot of those that ventilatory drive that these patients need. With the ECMO, we can go ahead and extubate them. Patient was extubated, everything was doing great. And about 2 hours later, they pulled the cannula. So one of the great things about ECMO is this patient went from 7 days of going through what to try and breathe to getting resolved in less than 24 hours, all because the patient was able to be managed safely. They could get all the drugs and medications on board, and the patient, we could rest their lungs with adequate ventilator settings. And it ends up having a positive note for this patient. She ends up getting discharged 9 days later after a very fruitful experience with ECMO and asthma. And then she gets follow-ups with the ECMO clinic where they just make sure that there's no long-lasting effects, because there's a scenario that happens with some patients. They get what's called pump head. And sometimes that non-pulsatile flow going through the body can sometimes mess with people's mentation. It can cause problems for kidneys and different things like that. But this patient, where they were going, it was not survivable. So this was something that was definitely in their best interest. Yeah, ECMO lag. We can call that ECMO lag. Wade just came up with a new term. So one thing I would love to talk with you guys about, we've got a couple of minutes here. There's something that, is kind of always on everybody's mind lately. It came up about a year ago and everybody's been asking a lot of questions about it. And at the time, unfortunately, this patient, as you can see, This patient was in 2017. So back then we weren't really thinking a lot about this one. But you know what? Something to look at beforehand. And this is something that we should all remember because it's available at every facility we've got. If you're at Clovis, if you're at Fresno Heart, anywhere you're at, they have anesthesia machines. So for years, volatile anesthetic gases have been used to treat acute bronchoconstriction or asthma for that matter. But in this case, it wasn't attempted. Why? Well, it wasn't thought about. So what is our choice gas? What's the one that our facility likes to use the best? There's a couple of them out there, but sevoflurane, or AKA Sevo, is also the one that we have the choice. There's a couple of reasons why. Oh, sorry, just had an email pop through and make a big noise in my ear. So what is sevoflurane? Well, like I just described, it's a volatile anesthetic gas that's classified as a halogenic ether, like desflurane and isoflurane. Well, desflurane, I can tell you just by looking at the research that I did, desflurane isn't very popular with this treatment. The reason why is it actually causes bronchoconstriction. It can cause uncontrolled coughing because it's a very irritable gas. Remember, these are volatile gases. So this is something that's going to end up causing some inflammation. Now, isoflurane, here's one of the things about isoflurane that I could find is that it is a very, very effective anesthetic gas. Well, when you use this at very low doses, it's harder to control. So they have to do just this minimum alveolar concentration dose, and it has a much lower MAC than any other one, like a bolus. So when you use it, it's so much more effective. It actually will oversedate the patient. This is one thing that I love about these anesthetic gases. How does it work? Nobody knows. They think that it enhances the inhibitory receptors and it dampens the excitatory pathways. So basically, it causes the parasympathetic system to kick in and the sympathetic system to go away. Now, here, this is something I would like to point out to everybody here. Whoop, gosh darn it, I clicked. I was trying to highlight that and I clicked it. So this may suppress motor response via the muscarinic receptors. Well, isn't there something that we give, Chris? Something that's an anti-muscarinic? I think there's some medications out there that are anticholinergics that we give that provide this type of therapy. So when we're giving Atrovent, we're kind of doing this very same thing here, and it's called the cholinergic tone that we're fighting. But right now, basically, it's magic fairy dust. We don't know how it works. How is it given? Well, it's given via a vaporizer. No, there's not some guy out there in the parking lot with a vape pen smoking up and sevoflurane, but it is given on the kind of the same type of premise. It's connected to an anesthesia machine. A lot of us call it the anesthesia vent, but it has to be administered through that device. How is it dosed? Well, a lot of people will observe that there is a measurement that they're targeting or that they are measuring on the exhaled tidal volume of the patient. And what they're trying to determine is how much of this is coming back. And you'll look at it and it's like 1.2%, 1.7%. Well, that is the concentration that they're looking for. They're looking for a targeted minimum alveolar concentration, or MAC. Now, MAC is, without going into great detail, a MAC of 1 is considered enough to sedate 50% of the population. What they're shooting for is a MAC of 1.2, which is enough to sedate 97.6% of the population. Who administers it? Not RCPs. If you guys remember, the reason why I'm putting it this way is the RCPs have a lot of things under their license. There's a lot of things that our license allows us to do. There's 2 of them that we can't do. We can't cut live tissue, and we cannot pass anesthetic gas. Is that the right way to say that? Administer anesthetic gas? Yeah, passing gas. I don't know if that sounds right or not, but we cannot administer anesthetic gas. So if you've got a patient who is on sevoflurane and they need to go to IR or they need to go to CT, guys, we cannot stop this treatment and we cannot start it. The anesthesiologist has to do it. Or if you extubate it, if you disconnect it, we cannot mess with this stuff. It is outside of our scope. So please remember that. So why Sevo and not other anesthetics? Well, sevoflurane preserves systemic vascular resistance. It preserves cardiac output, but it does not preserve systemic vascular resistance. In other words, the patient's blood pressure might drop slightly, but it's going to allow it. So it's going to allow the heart rate to come up to compensate for it. It doesn't wipe out their systemic vascular resistance, kind of like propofol does. It doesn't truly depress respiratory drive like a lot of other anesthetic gases do, and a lot of anesthetic just medications will do. It doesn't cause bronchospasm like you'd heard me talk about before. Desflurane actually can cause, I shouldn't say it does, it can cause bronchospasm. Another one is, does anybody know what I mean when I say Special K? Has anybody heard of Special K? Wade's heard of it.
It's my breakfast in the morning.
Yeah, Carrie's not here anymore.
Yeah, so Special K is ketamine. So ketamine has this little scenario that happens to some of our patients that's called going down the K hole with Special K. It's basically very vivid and extremely literal hallucinations. These patients think they're literally in another world. Another thing about SIVO is it is extremely easy to administer, and it is very reliable. We know exactly what it's going to do with every patient. Some things that we need to take care of. Why would you not use SIVO? Well, SIVO can cause nausea, vomiting. We've all seen the patient in the recovery room that's sitting there dry heaving, throwing up, or they're complaining that they're very nauseous, and the nurse will come in and provide medications for that. It can also cause spontaneous abortion during pregnancy. This is including the healthcare worker. So if you are taking care of this patient, you think you might be pregnant, or you are trying to get pregnant, stay out of this room. This can cause major problems for your pregnancy. And one thing that happened with one of our patients, and it was really interesting with the transport that came up, is that we had a patient that was on SIVO. She was, I'm going to talk about her in a little bit, but she went through this case and ended up blowing out one of her pupils, and everybody panicked, thought she was having a stroke, and they took her to CT. This is actually something that can happen with these patients. So anyway, so I want to go through a quick patient case study. So this is about 2-3 years ago. I'm very sorry, guys. I did not get the MR number for this patient, and there's a lot of information that I'm going by memory. But it was a 17-year-old female who had been admitted to the ED with severe asthma. She had chronic uncontrolled asthma coupled with marijuana use and had 6 prior intubations. Guys, you understand that when you see prior intubations, that this is bad. This is uncontrolled, unmaintained asthma. So this patient at home used her entire inhaler, and that was why she came to ED. When she came to ED, she ended up getting numerous hour-long treatments. She was intubated for a pH less than 710 with the onset of hypoxia. This is something that I've always gone by. You know what? You can have hypercapnia with an asthmatic patient, but when they get hypoxic, everything's done. We got it. We got to start moving fast. So she received Q4 15 milligram treatments in the ICU. This patient was getting a couple of days of these treatments. Every time we would get treatments, one of the RTs calls up and says, hey, every time I start this treatment on this patient, her airway resistance goes up, her tidal volumes drop, everything changes. It's almost like she's rejecting the medicine. So I went in there and looked at her, and of course, when she was getting the treatment, that was true. It looked like she had an albuterol allergy. So they changed it to 5 milligram, which is the equivalent for an hour-long 5 milligram treatment for levoalbuterol, Zopanax, and that she still had the same reaction. The RCP was standing there talking with the physician and said, you know what, maybe we should try sevoflurane or some type of anesthetic gas that we've got. Is there something that we can do? They had a little powwow, came up with the anesthesiologist. The anesthesiologist looked at her and said, yep, we can do it. They put her on SIVO for 24 hours, and it was out of caution because the patient immediately turned around. Within about 10 minutes, a lot of her tidal volumes went up because they had her on pressure control. Her tidal volumes went way up. Airway resistance plummeted. There was a lot of things that happened. Heart rate came down, and she started looking a lot better. But just because it was the first time that we'd ever done it in this facility, they wanted to keep it on there for about 24 hours. At 24 hours, she was weaned. The sedation was cleared. We were doing neurologic checks on her, and she was extubated. This patient ended up becoming one of the last times we ever saw her in the ED. That was one thing I do remember about her is she had a fairly significant history with coming into the ED with asthma, and this was something that once she got it under control and found out that she did actually have an albuterol allergy, a lot of things turned around for her, and her asthma was a little bit more well controlled with other medications. So that's all I have for sevoflurane and for ECMO. But one thing I would like to ask everybody is, what would have happened with both of these patients if they would have had the proper education, if they would have had the proper time with a professional sitting with them and going over their triggers and going over everything that they need to keep themselves well maintained? What would have happened if we would have done an asthma referral for this patient and gotten them the help that they needed and followed them up with pulmonology? This is something that we can all do, especially you that work in ED, that you're saying, oh God, Darren's back again. He's having another asthma attack. Well, a lot of times these patients don't want to come into ED. This is not something that's the highlight of their weekend. This is something that we need to step forward and say, hey, okay, let's do an asthma education consult on them. So remember, we can put these orders in. All you got to do is talk to the physician, say, hey, outpatient, I'd like to do an asthma education referral for this patient. The referral number's at the bottom. It's REF 142. That pops up, and it actually sends the order out once the patient's discharged. And with that, that's the end of our talk. Would love to hear from any of you if anybody has any questions or anything that they would like to talk about.
I've had a real bad patient that came from Hanford years ago. The patient coded twice on the way here. They're trying to do a high rate ventilation, and they got here. I mean, I always keep about 300 the auto peep, and I just kept going up. As a matter of fact, I mean, because they were getting like pressure control 40, they're getting like 100 cc volume, but I just kept going up on the peep, and when I peep at 30, I think we'll go to straight CPAP. They're able to ventilate, and then the albuterol actually worked at that point. And I was able to wean down the peep, and by 7 o'clock that morning, she was extubated.
Yeah, that's a good point. One of the things that I sometimes we all forget about, when we turn down the PEEP on a patient, a lot of times one of the first things that happen is all these secretions start coming up. We always hear that patients on bi-level 28/0 and we can't suction anything out of them. But when we wean those pressures, all of a sudden everything starts coming out. The same thing happens with medications. When you have these huge pressures in a patient's chest, you can't get the medication in to where it needs to be. These patients need to breathe spontaneously. And there's actually some articles out there that say when a patient is on high flow and getting continuous nebs through the vibrating mesh or through the aerogen, the deposition is actually higher when they're distressed breathing because they're pulling in such large volumes, and you can get the medication down there further. Now that doesn't apply to when you start doing you know, like volume control mode on the vent and stuff, thinking that you're stuffing the medication down there. But when the patient breathes on their own, like you said, when you put her on CPAP, you're going to get a lot more medication down inside. Thanks.
Well, I said they weren't on CPAP. I mean, I had to turn down the pressure control because once I got enough PEEP on there, their volumes jumped up big. I just kept turning down the pressure control where it's normal volumes, which is basically CPAP. They just need the PEEP. I mean, it's like a PEEP of 30 and pressure control of 5, and they're getting 500 tally volumes, and then I was able to start weaning down the PEEP at that point. So that medicine actually got down where it needed to be.
Yeah, I mean, it's all patient individualized. There's not going to be too many patients out there that you're going to see frequently that require that high a PEEP level. So you know,
yeah, but if she's been made like 3 or 4 times before, she coded 2 times. I mean, her CO2 is 190 and 200, but they got in Hanford, the gases were.
Yeah, that's great. I appreciate
it. As a matter of fact,
Ken.
the RT from Hanford, I mean, I already started ventilating. I said, what did you do to get this patient breathing? It's like they had no idea what to do out there. Anyway.
Well, I mean, that's similar to what I was discussing earlier, right? You modify the settings for them to get gas out of their lungs. So that's good work, Kent. Now, did you refer them to the asthma referral program so we didn't see them coming back?
Yeah, this was quite a few years ago, and I don't recall if we had that at that time.
Well, just, you know, that's why we had I put a plug out that for, because remember, that's one of the important parts of those programs is trying to keep these patients from coming back in the NT though. Thanks for sharing, Kent. We appreciate it. Does anybody else have any questions for us? You know, so before you guys go, for anybody that there's references at the back if you guys want me to send those, but for any of you that are not RTs on the call, and again, we appreciate you joining us. Thank you. Love to hear from you if anyone has an experience, but that's okay if nobody wants to speak up right now. But on the screen, I've got my email address on there. So this case study is approved for 1 CEU, and that's for RTs, RNs through the BRN provider. So any of you that are not RTs online that would like to get a CE credit for this, please email me and I will send you an evaluation form. And you fill out the evaluation, send it back to me, and I'll send you a certificate. That's how that works. For our staff of the respiratory, you guys know where to go. Go to the website, go into the list, go to the April case study, complete the evaluation, and I'll wait till at least a group of you guys that completed it, and I'll email you guys out the certificate. So now that did I get anybody else to build up some courage to ask a question or comments or anything?
I have a comment real quick. So you know how we give continuous albuterol through the aerogens. What's a quick way to know when you're giving report at the bedside that if your patient's receiving it? Just by looking at their vitals, that they're actually receiving the medications. Anybody out there have an answer? Anybody?
What is the question again?
So if your patient's receiving continuous albuterol, what's a quick way to know that they're receiving the medications by looking at their vitals?
Well,
How do you know
I
they're
mean,
receiving?
heart rate should be elevated. I mean, it should be one question there a little bit.
Absolutely. So just know when you're getting, when you're going around looking at your patients, if their heart rate isn't elevated, they're on continuous albuterol, go check your acorns, go check the neb. It may not be nebulizing. So it's really important to check those because I've seen it, and I think we've all seen that when our aerogens are just not nebulizing. So it's really important to make sure that that medication's going. Thanks, Ken. Yeah, they could be clogged up or something's going on. So just make sure you check those frequently. Thank you.
Thanks, Chris. That's a good point.
And I
All
miss Bronchosol.
Yeah, some of us do, Kent. But some of the patients didn't like it.
Well, I'd pop them open immediately real quick there. Then they breathe a little bit better. Then you get the albuterol can work a little bit too, though. Yeah.
Well, they also didn't like the tachycardic and the feeling of their heart jumping out of their chest too either. That's the one thing they always remember. All right, so it is time. Anybody else? Last comments, questions? Again, remember for nurses or anybody else not with our department, if you want CE credit, please email me. The rest of the RTs, go to the website, fill out the application to get your credit. Thank you so much, everybody, for joining. We actually had a total of 34 participants joining us. That's makes me feel proud that we're able to do this. Obviously, something tonight was new, and I hope you guys enjoyed it with the kind of a 3-part section of 3 different presenters presenting different sections like that. And by the way, remember on the evaluation, if you guys got any ideas or future things you want to listen to, please, we have a board right now that we're going down the list right now that we're keeping track of. And we're trying to, you know, we only do 1 a month, so it'd be hard. If we did 1 a week, maybe it'd be a little faster. But you guys got any ideas or topics, please let us know, send it off to us. Gentlemen, anything else last to say?
Thank you.
Thank you, everybody, for joining us. We appreciate seeing you all virtually. Hopefully, we can start doing this live here pretty soon.
I appreciate everyone
Thank you.
for joining in today. Very good presentation.
I like the Zoom though. You get a lot more people to participate too with the Zoom though.
Well, if we go back to live, we would definitely do a hybrid where it's Zoom / in person.
Okay, yeah. All right. Thank you all.
Thank you, everybody. Have a good night.
Thank you, Amont.